Nice to meet you. Name is Dökmeci. Yes, Dökmeci. My surname is Dökmeci. My first name is Fatih.
Now we will start HCC 10. Optional treatment selection in hepatocellular carcinoma. This session will be chaired by Professor Mitsuo Shimada, Professor Masayuki Kurosaki, and Professor Kadia Dukmeshi. Moderators, please start.
Okay. Okay, good afternoon, everybody. So it's time to start wonderful, interesting session, Symposium 10, HCC. Our title is Optimal Treatment Selection in HCC. We have 4 distinguished guest speakers and 3 chairmen and 1 discussant, Professor Okawa. So I'd like to introduce the first speaker, Dr. Wasim Jaffrey, Pakistan.
Instead of him, I replaced because he is sick. So my session was at the beginning, I mean in the morning. So they changed instead of Wasim Jaffrey.
So you're gonna speak? Okay, please.
Professor Necati Örmeci from Turkey. Now he's going to speak instead of, Professor Jaffrey.
Okay. Mr. Chairman, ladies and gentlemen, first of all, I would like to thank the organizing committee for giving me a chance to show my speech regarding follow-up strategies of hepatocellular carcinoma. I have no conflict of interest. Hepatocellular carcinoma is the 5th most common cancer among malignancies in man and all over the world. It is the 3rd most common leading cause of death and one of the leading causes of death among patients with cirrhosis. Hepatocellular carcinoma represents about 90% of primary liver cancers and constitutes a major global health problem. HCC accounts for more than 300,000 deaths in China and more than 650,000 deaths worldwide every year. So annual HCC incidence was highest in Asian Pacific Islanders, followed by whites and the then African Americans. Patients detected at an early stage can achieve 5-year survival rates of 70% with transplant or resection, whereas those with advanced hepatocellular carcinoma are only eligible for palliative treatments and have a median survival of less than 1 year. So who should be screened? HCC surveillance is fundamental to improving early detection, curative treatment received, and the survival in patients with cirrhosis. American guidelines suggest keeping surveillance on Asiatic HBsA antigen positive males older than 40 years and females older than 50 years, and younger ages for Africans and African Americans. HBV could develop HCC at an earlier than 40 years. So Europeans apply surveillance on HBC antigen positive patients at high risk of HCC after stratification according to scores, grade of fibrosis, while Asians have recommendations similar to those of Americans. So roughly, surveillance of the patients with high risk of hepatocellular carcinoma continue liver cirrhosis, hepatitis B or delta infection and related conditions, HCV infection, heavy consumption of alcohol, other inflammatory conditions such as hemochromatosis, alpha-1 antitrypsin deficiency, primary biliary cirrhosis, primary sclerosing cholangitis, autoimmune hepatitis, non-alcoholic steatohepatitis, male gender, older age, high body mass index, and certain Asian and African races, family history of HCC, aflatoxin exposure, persistent increase of ALT, increased AFT, and progressive impairment of the liver function. Aim of the hepatocellular carcinoma surveillance. The goal of surveillance is to detect HCC at an early stage when it is amenable to curative therapy and to reduce all cause of mortality. First, HCC risk must be high enough in the at-risk groups to justify surveillance. Second, surveillance tests must accurately detect HCC at an early stage than it would otherwise present because of symptoms, signs, or incidental imaging. The third, effective treatments which improve outcomes in screening detected HCC compared to treatments for non-screen detected HCC must be applied. So this is one meta-analysis, early detection, curative treatment, and survival rates for hepatocellular carcinoma surveillance using by ultrasound with or without alpha-fetoprotein in patients with cirrhosis. Almost 47 studies, more than 15,000 patients, and 41.4% of them had hepatocellular carcinoma. So when we saw the result, association between hepatocellular cancer surveillance and early tumor detection rates. So surveillance group had much more tumor in early stage compared to non-surveillance group. Also, association between HCC surveillance and curative treatment rates. So surveillance group had much more curative stage HCC compared to not surveillance group. Also, the third association between HCC surveillance and the survival. Of course, surveillance group had much more survival compared to not survival group, surveillance group. Another very nice study, randomized control study, screening of hepatocellular carcinoma. So more than 9,000. They surveillance AFP plus ultrasound in every 6 months. 6 months. So when you compare the screening group and the control group, in the screening group, stage 1, almost 60.5% of the patients was in the stage 1. Also, 45.3% of the cases had a small hepatocellular carcinoma, and also resection, 46.5% had a resected resection chance to resect. Compared to the control group, as you see here, no any stage 1 patient, no small hepatocellular carcinoma group, and the resection only 7.5% of the cases. So when we look at the 5-year survival, 46.4% of the cases had a chance to survive almost 5 years. Surveillance program, cirrhotic patients for early diagnosis and treatment of hepatocellular carcinoma is a kind of cost-effectiveness analysis. Ultrasound and AFP in 6 months intervals, 313 liver cirrhosis were surveilled, and 104 cases had hepatocellular carcinoma. Hepatocellular carcinoma detected in surveilled patients, almost 36 dead and 25 censored. HCC detected in unsurveilled patients, 95 dead and 9 censored. So that means dead persons, of course, less in the surveillance group. When we look at the cumulative survival rates in patients with liver cirrhosis enrolled in the study and patients with incidental hepatocellular carcinoma stratified according to the Child-Pugh class, liver cirrhosis and Child-Pugh A class, stage 1, you see, and the liver cirrhosis and Child-Pugh B or C class, 2, 3, HCC and Child-Pugh A class, this one, and the 4, HCC and Child-Pugh B or C class. When you compare the 1 and 3, this is very important significance, statistical significance, and also 2 versus 4. There's a significant importance. And also survival, of course, the most survived patients belong to the group 1, and then 2, and then 3, and 4. There are several harms of HCC surveillance, but I think it's not necessary to mention it because it's not so important. So another huge randomized clinical study, more than 17,000 HPV-infected persons randomized for surveillance, and prospective study of early detection for primary cancer. The 1 and 2 year survival rates for HCC patients in the surveillance group were 88.1% and 77.5% respectively, compared to non-surveillance group, almost 0 and the 1 year, and the HCC patients in non-surveillance group. This is another randomized clinical trial, screening hepatocellular carcinoma, more than 18,000 HPV carrier, and it was reported that higher early tumor detection and curative treatment received among patients randomized to HCC surveillance. HCC-related mortality of patients undergoing surveillance was significantly lower than that of no surveillance arm, with hazard ratio of 0.63. So when we look at the risk factors, untreated HCV-HBV, in those patients established risk factors such as cured HCV, suppressed HBV, and the NAFLD. Incidence and determinants of HCC in autoimmune hepatitis, systemic review and meta-analysis, 25 included 25 studies and more than 6,000. So when we look at the results, if autoimmune cirrhosis, the patient has autoimmune cirrhosis, then we should surveillance those patients because of high risk of hepatocellular carcinoma. So as you see here, HCC incidence for this subgroup was from 0.80 to 29.76% for 1,000 person years. But without cirrhosis, in those patients, HCC incidence rate very small. It was 1.114 per 1,000 person years. Annual incidence hepatocellular carcinoma among patients with alcoholic cirrhosis and identification of risk groups. Also, when we look at this research over the follow-up patients period, 62 patients had developed hepatocellular carcinoma and age higher than 50 years, 55 years, and platelet counts less than 125,000 millimeter cube. Those patients had a high risk for developing hepatocellular carcinoma. So in the alcoholic patients, we should look at the age and the platelet levels. So which modality should be used? HCC with low and normal serum alpha fetoprotein levels, a large database 1,773 HCC patients in Turkey was examined. 41.9% had alpha-fetoprotein levels less than 20 international unit per LR. So additional 16.123% had values between 20 and 100 international units. So this 58% of the cohort less than 100 international unit per ml AFP levels. So was found already in the study. 66% of the patients with small, less than 5 centimeter HCC had low AFP compared to 49% of patients with larger than 5 centimeter HCCs. So the quality of ultrasound examination for exclusion of liver masses among 941 patients, ultrasound were inadequate in 191 cases. So 134 definitely inadequate and 57 likely inadequate. So totally more than 20 patients, 20% of the patients are inadequate for the examination of ultrasound. Ultrasound, abdominal ultrasound, alpha-fetoprotein for the diagnosed hepatocellular carcinoma in adults with chronic liver disease. So when we look at this AFP, cutoff level 29 nanogram per ml. So sensitivity 59%, specificity 84%. If you get cutoff 200 nanogram, in those patients, just sensitivity becomes low, as you see, 36%, but sensitivity, specificity becomes higher, 99%. Ultrasound, sensitivity 72%, specificity 94%. If you combine ultrasound and the AFP together, then sensitivity is increasing until 96% and the specificity 85%. Diagnostic accuracy of magnetic resonance imaging for the diagnosed hepatocellular carcinoma, MRI also can miss the diagnosis of HCC and can incorrectly diagnose HCC in 6% of the people who would receive unnecessary treatment. So we should be careful. Also, CT is detecting hepatocellular carcinoma any size and stage. 22% of people with hepatocellular carcinoma would be missed, and the 8.7% of the people without hepatocellular carcinoma would be unnecessarily treated. So what's the optimal time interval for screening of HCC? So I think I should omit some slides because if you compare more than 7 months or less than 7 months, less than 7 months is much more better results. So corrected survival of patients under semi-annual surveillance versus observed survival of patients under annual survival. So if you surveil the patients higher than 7 months, then 6-fold higher risk of missing hepatocellular carcinoma, less than 2 centimeters in diameter. Okay, if you compare 3 months to 6 months, almost no difference, just the one difference. You can catch less than 10 millimeter in diameter tumors, a little bit higher than the other one. So in this study also, there was no difference between the 6 months and the 3 months comparing. How to follow up the patients with HCC after resection, radiotherapy, TACE, or transplantation. So clinical and biological evaluation every 3 months for the first year, and then every 6 months. Chest CT scan every 6 months for 2 years. Liver imaging, MRI, liver ultrasound examination every 3 months for 2 years. After this, monitoring screening of the new HCC may be done by MRI or hepatic ultrasound every 6 months all life. After radiotherapy, MRI is the best technique for catching the HCC, but should not be programmed too early because rather than 3 months after the end of the radiation. So 6 weeks after the TACE clinical and biological evaluation, plus CT scan without injection in the case of TACE with lipiodol should be performed. After transplantation, the patients should be followed up closely by MRI during 2 years in every 3 to 6 months. So how to screen recurrence HCC after radical treatment procedure? NCCN guidelines recommend multiphasic imaging every 3 to 6 months in the first 2 years after radical treatment, while ESMO guideline proposes enhanced CT and MRI every 3 months in the first year and every 6 months thereafter. ASEAN Pacific Association for the Study of Liver, ASLD, and EASL consensus recommendation on hepatocellular carcinoma. As you see here, surveillance for HCC in high-risk population is recommended, and the surveillance HCC should be performed by ultrasound and alpha-fetoprotein every 6 months. You see here almost many guidelines just recommend ultrasound plus AFP every 6 months, except EASL. EASL only recommend ultrasound examination. Let's forget this one too. Mr. Chairman, ladies and gentlemen, as a conclusion, surveillance should be offered for patients with cirrhosis, irrespective of etiologies, when the risk of HCC is higher than 1.5% a year or greater. HCC surveillance is associated with a smaller tumor size, lower alpha-fetoprotein levels, earlier BCLC tumor stage with impact on therapeutic strategy, resection, transplantation, or radiofrequency ablation more often applied. It is an independent predictor of increased survival with significantly higher 1, 3, and 5-year survival rates and a reduction in mortality. US and alpha-fetoprotein serum measurement in combination are used as a triage test before CT and MRI. CT and MRI play a role on tests to confirm the diagnosis and the 2-stage diseases. Semi-annual surveillance intervals were associated with improved early HCC detection and overall survival compared to longer surveillance intervals. It is recommended to perform at least 3 follow-ups every year for high recurrence risk patients in the first 2 years after ablation, while in low recurrence risk patients, it's recommended to perform 2 to 3 follow-up every year. So a few studies characterize surveillance-related harms, although available data suggests surveillance harms are mild in severity. Thank you very much for your patience.
Thank you very much, Professor Necati Örmeci. I would like to give just a short introduction for him. Actually, both of us from Ankara University School of Medicine in Turkey. And he just graduated from the Ankara University School of Medicine. Then after that, he started to work in Ankara University. After that, he studied in Japan 2 years in women culture and also I think cancer center in Tokyo. And he became a member of the executive council of APASL. And actually, he is acting as a very, very full member of APASL more than 20 years. Now I'll give you very, very happy news because just yesterday, the steering committee bid for Necati as a 2026 president of the APASL. Now we have to congratulate him.
Thank you very much. Thank you very much.
This is the second annual meeting in Turkey. It was the first time 2015 in Istanbul, again in Istanbul, and also we as a Turkey we organized 3 single topic congress also. And now we start the discussion. Thank you very much. This is excellent speech.
Thank you very much, moderator.
I would
Thank you
like to add something. You know, the surveillance and also to screen of the recurrence of the hepatocellular carcinoma is very important. We have to use alpha fetoprotein and ultrasound in every 6 months. But I would like to add very important 2 biomarkers. One is the DCP and also alpha fetoprotein level 3, L3. I think, especially in the United States, in Japan, they are using very much. But in Turkey, still, we couldn't use that. I believe that alpha fetoprotein L3 and also DCP, even alpha fetoprotein level is not so high, then we measure these 2 other markers, we can, you know, catch some case of the hepatocellular carcinoma. Okay. How about my co-chairs? Would you like to ask something, or our discount Professor Okawa give some discussion? Okay.
Thank you for your excellent presentation. I'm a discussant of this session. My name is Kazuyo Shoka from Japan. You showed the importance of HCC surveillance for early diagnosis of HCC and to much improve the prognosis
Survival.
of this disease. The measure the optimal use of imaging modalities is ultrasound and in addition to alpha fetoprotein measurement. But we often encounter the patients with obesity in whom ultrasound is not applicable. What do you think? What modalities should be used in such a patient?
Thank you very much. This is a very important question. First, we have to check the fibrosis levels in those patients. If the patient had a F3 or F4, then of course we have to check. If ultrasound examination not satisfied, then of course we have to use the MRI or CT imaging method.
Enhanced or non-enhanced?
Enhanced, of course.
Thank you.
You're welcome.
Okay, now my co-chairs. Do you have any question or comment?
May I ask you one question?
Please.
You showed the cutoff of alpha fetoprotein of 20 and
Yeah.
200. And according to the specificity, higher cutoff may be variable. But actually, what kind of cutoff do you usually use in your clinical practice?
Generally, we use 20 nanogram per ml, but some clinics use 5 nanogram per ml also.
And,
But if we use 200 sensitivity, very small. So, okay, specificity is higher, but sensitivity very small. So I think it's better to use 20 nanogram.
Okay. Do you change the cutoff value according to the etiology of liver disease, such as viral hepatitis, autoimmune, or muscle disease?
Yeah, autoimmune hepatitis, if the patient had a cirrhosis, then of course we have to check the survival the patients. But as I mentioned that if you increase the cutoff level, then sensitivity will be decrease and decrease. So it's better not to decrease the sensitivity also. We should increase the sensitivity plus specificity. For this reason, AFP and the ultrasound examination is combined is better.
Thank you.
Now this discussion opened for audience. Yes, Murat, another Turkish professor.
Professor, thank you very much for excellent speech. My question is the hepatitis B or hepatitis C patients, sometimes hepatitis activity and sometimes we can see the AFP elevation. In these cases, what do you recommend?
So thank you very much. This is also another question, important question. So if inflammations increase, then AFP also can increase. So we have to be careful in those patients. We have to check the fibrosis levels again. If fibrosis level is higher than F3, then sometimes we have to use not only ultrasound, but also the other imaging techniques we should use.
Thank you. Is there any other question? Then, okay. Thank you very much, Professor Necati.
So I'd like to introduce second speaker. Second speaker is Professor Yeonjun Kim, head of Department of Internal Medicine, Seoul National University. So his title is Optimal Use of TRARE in Advanced HCC in the Era of IO.
Thank you, Chair.
Please.
Thank you,
start.
Chairman. I'd like to start my speech with this slides. The TRE is recommended only for the single lesion less than 8 centimeter. In the case of ablation, resection, transplantation, is not feasible or failure in the patient with very early stage, or intermediate stage HCC. And in clinical practice, TRE are widely used from very early stage to intermediate stage. But I do believe that TRE can be used from across all the stage of liver cancer, from very early stage to terminal, even to the terminal stage. And actually, Seoul National University Hospital is one of the center of excellence regarding radioembolizations, and we performed more than half cases in Korea, reach to 400 cases a year. Also, we have established the Korean Radioembolization Association in 12 years ago, and this year we will host 17th symposium, and this slide was from the 18th symposium. And I'll show some published data from my center or our Radioembolization Association. First, the TER can be used in the intermediate stage HCC, and we have shown the yttrium-90 radioembolization is associated with better clinical outcome in patients with hepatocellular carcinoma compared with the conventional chemoembolization with the propensity score match study. About BCLP patient consists of about 40% of enrolled patients, and here you can see the overall survival was significantly better in the entire study population, as well as the patient without metastasis and patient with stage B or C, and patient with tumor diameter more than 5 centimeter. Also, in advanced stage, we compared the result of radioembolization with those who treated with TKI. And radioembolization was a safe and effective treatment for hepatocellular carcinoma with portal vein thrombosis with this propensity score matched analysis. And here you can see about 100% of patients have portal vein invasions, and ALT level was about 15 to 19. And here, the response rate was significantly higher in radioembolization groups, and complete remission was only observed in radioembolization treated patients, and it continues up to 6 months. And in terms of survival, the overall survival is not significantly different after inverse probability weighting, and time to progression was also quite comparable. However, in terms of adverse effects, radioembolization was significantly, radioembolization treated patients experienced significantly fewer adverse events compared to those of sorafenib treated patients. For example, diarrhea was significantly fewer and bleeding was significantly fewer too. And we expand this study to multi-center study, and we repeated the better result. So in transarterial radioembolization versus tyrosine kinase inhibitor, including sorafenib, lenvatinib, regorafenib in hepatocellular carcinoma with portal vein invasion. And this is conservative diagram. We enrolled 265 patients, and TAIR group consists of 124 patients, and TKI group consists of 92 patients. And we compared the balance code using either IPTW or PSM. In this study, TAIR is associated with better overall survival compared to TKI in HCC with BP portal vein thrombosis 1, 2, 3, portal vein tumor thrombosis. And here you can see the median overall survival TAIR was 28.2 months, which was significantly longer than that of TKI, which was only 7.2 months. And TAIR was independently associated with a low risk of death. And similar results were reproduced in the cohorts balanced with either IPTW or PSM. And TAIR was associated with a lower risk of hepatocellular treatment-related adverse events again. Here you can see in terms of PFS, there was no significant difference between TAIR and TKI-treated groups. In terms of adverse event, again, the side effects of adverse events were significantly fewer in TI-treated patients, such as ascites, hepatic encephalopathy, or increased Child-Pugh score by 2 or greater. Now, this is era of IO, so we compared the result to TAIR plus atezolizumab plus bevacizumab. This result is in writing, so I just show one short slice, and here you can see the overall survival. Here you can see this is a matched cohort. TAIR is associated significantly better overall survival as well as progression-free survival. And after this overall survival in a matched group and matched group, the overall survival was significantly better in matched groups, but progression-free survival was almost comparable. Also, we have developed a prognostic prediction model of transarterial embolization in hepatocellular carcinoma, which we named SNAP-HCC score. SNAP-HCC score consists of maximal tumor size, tumor number, serum albumin, and portal vein invasion. And here you can see the clear distinction according to the SNAP-HCC score. And if the patients have a SNAP-HCC score 0 or less than 1, here you can see 5-year overall survival is more than 82%. And in early HCC, we compared long-term outcome of transarterial radioembolization for large single hepatocellular carcinoma, which was compared to resection. Also, EASL guideline recommend resection for large single nodular HCC. However, large tumor is related to poor post-surgical outcomes, such as high recurrence rate, vascular invasion, poor histological differentiation grade. Indeed, 5-year disease-free survival is only 20 to 40%, even after a curative resection in huge single nodular HCC. Therefore, we need alternative treatment, and this is unmet medical needs. However, recent meta-analysis clearly shows conventional TACE, which is one candidate, is associated with worse clinical outcome than resection in meta-analysis. So we compared TARE versus surgical resection for large single hepatocellular carcinoma. The aim was to compare the long-term outcome, whether TARE can be a potential alternative to resection in huge single hepatocellular carcinoma. And this study design was a retrospective cohort study from 2 large referral centers in Korea, and inclusion criteria includes newly diagnosed HCC, single nodular HCC more than 5 centimeters, and initially treated with TARE or surgical resection. About 14,000 patients diagnosed as HCC from January 2012 to 2020, and 557 patients was included in the study after exclusion, and TARE group consists of 57 patients, and the resection group consists of 500 patients. And here you can see this is baseline characteristics. Age was older in TARE groups, and ASS classification was poorer in TARE groups. Tumor size was larger, much larger in TARE groups, and bilobar involvement was more frequent in TARE groups, and level of portal vein tumor thrombosis was higher in TARE group. Collectively, TARE-treated patients have many poor prognostic factors. However, the overall survival before correction was quite comparable, and 5-year overall survival was 75% in resection groups and almost 67% in TARE-treated groups. And tumor progression was also very similar. However, intrahepatic tumor progression was a little bit earlier in TARE-treated groups. However, after IPTW, overall survival was completely overlapped, as well as tumor progression and intrahepatic tumor progression. And TARE was not a risk factor for overall survival in multivariable analysis, as well as time to progression and time to intrahepatic progression. And again, safety assessment clearly shows the better result in TARE-treated patients. The overall incidence was clearly pure in TARE-treated group compared to resection-treated groups. Also, admission days were significantly shorter compared to resection groups, 3 days, 12 days. So, older age, BDAC classification, larger tumor, bilobar involvement, VP2, patients is more likely to be treated by TARE. However, after balancing by IPW, the overall survival, time to progression, and time to intrahepatic progression was comparable, was not significantly different. And TARE was not an independent risk factor for overall survival, time to progression, and time to intrahepatic progression. And TARE is associated pure adverse events, as well as short hospital stay. So we are planning the prospective study comparing transarterial radioembolization versus surgical resection for a single hepatocellular carcinoma less than 8 centimeters, which is exact indication recommended by BCLC. And this is MESUS. We randomized both groups, and we permit crossover between treatment modalities. So I hope you can present the result in the near future. We are planning this study. And in the advanced stage, I think that the TARE can be combined IO drugs. And previous study shows tremelimumab can be combined with ablation such as RFA cryoablation in patients with advanced hepatocellular carcinoma. It includes THCE. And another study shows radioembolization with yttrium-90 resin followed by nivolumab for advanced hepatocellular carcinoma shows quite good objective response. The overall survival of the patients of this study was about 18, which is comparable to that of IO alone. So we published recently a phase 1/2A trial of yttrium-90 radioembolization in combination with durvalumab for locally advanced unresectable hepatocellular carcinoma. Study design was single-center, single-arm, open-label phase 1/2A pilot trial, which enrolled 24 patients in my centers. And key inclusion criteria was locally advanced HCC defined as BCLC stage B or BCLC disease without extrahepatic metastasis. This study design, yttrium-90 radioembolization was performed, followed by durvalumab 1500 milligram IV every 4 weeks. And primary endpoint was time to progression assessed by MLCist. We enrolled the whole patient in a very short period, about less than 6 months, and all 24 patients received yttrium-90 radioembolizations. And these baseline characteristics, hepatitis B HBV etiology accounts for 63% of those patients, and child pure classification A5 was almost 90% of enrolled patients, and BCL stage B accounts for 33% of patients. In efficacy analysis, median time to progression was 15.2 months, which is quite long, and median overall survival was not reached, and overall survival rate in 18 months was about 60%. You can see the objective response. We observed about complete response accounts for 30% of those patients, and objective response rate was 80%, and disease control rate more than 90%. In terms of safety, only 2 patients had grade 3 treatment-related adverse events. Grade 3 fever was related to yttrium-90, and grade 3 neutropenia was deemed to be related to durvalumab, but both were transient and asymptomatic. So in summary, in this pilot trial, the median time to progression was 15.2 months after median follow-up of 90 months, and the median overall survival was not reached, and 18 months overall survival rate was 60%, and the median progression-free survival was 77 months, and 6 months progression-free survival rate was 60 months, and objective response rate was 83%, and disease control rate was 92%, and while none developed any treatment-related serious adverse events. So this is case reports of example of clinical practice. 43-year-old Korean gentleman with a history of alcohol abuse. This is MRI. You can see multinodular HCC with some diffuse infiltration with portal vein invasions. And here you can see lymph node metastasis. And after TARE, the target region regressed significantly, and here you can see the regression of portal invasion after third cycle of atezolizumab, bevacizumab. So we are planning tremelimumab plus durvalumab in combination with concurrent transarterial chemoembolization in patients with unresectable hepatocarcinoma. And I also hope to present the result of this study in near future. So I think TRE can be used across the whole stage, in early stage for curative intent, or downstaging to transplantation, or bridging, or downstaging to surgery, or in intermediate stage for the better overall survival with fewer adverse events. And even in the advanced stage, we can treat those patients with TARE with IO drugs or anti-angiogenic drugs. So this is we exchange some knowledge regarding TARE with Taiwanese scholars. Hey, I can see Dr. Huang here. No? Yes, I was a little bit younger in this study. This is the first Korea-Taiwan TARE symposium held in Seoul. And this is 2023, 6th Taiwan-Korea TARE symposium was held in Taichung, Taiwan. And here I am a little bit getting older than previous photos. And now we are launching now expand our experience to the Asia Pacific region. So now we are hosting the inaugural symposium of the Asian Pacific Radial Embolization Association, APRA. So it will hold in June 2024 in Seoul. Please join us. And during the Liver Week. Liver Week is international conference hosted by Korea CASL, Korea Association of Study of Liver Disease. Okay, thank you for your attention.
Thank you, Professor Kim, for your excellent presentation. You clearly mentioned about the efficacy and safety of TARE and the possibility. So, you have a question?
Yes.
Yes.
Thank you very much. This is excellent speech, really. I know that you are the leading country for the especially living donor liver transplantation. And, but the important thing to have the real indication of the hepatocellular carcinoma. But there are some cases, for example, big and multiple hepatocellular carcinoma, and you have to have downstaging. The first question, do you prefer TARE or TACE for the downstaging? The second question, how about downstaging percentage for you to indicate for the liver transplantation?
That's very excellent question. Thank you, Dr. Dongmechi. I didn't show the result, but TRE is associated more favorable downstaging success rate. So we prefer TRE versus TACE. I prefer TRE, and the the downstaging rate is actually dependent on the aggressiveness of hepatocellular carcinoma itself. But generally, I can get downstaging success rate about 60%. 60.
Thank you.
Okay, Professor Okawa.
Thank you for a nice presentation about TARE. I'm much interested in the combination therapy of TARE with IO. In this therapeutic strategy, TARE, which do you think TARE plays mainly a role on localized therapy or immune enhancer of IO therapy?
Yes, it's a really excellent question. tear, radiation treatment or TRE is associated with a better immunological response because TRE or radiotherapy expose the tumor antigen to the immune system. So I think the TER combines very well with IO drug, but we need more prospect study. Actually, in clinical practice, we cannot use IO drug after TER. Only we can use IO drug after progression. So we need some limitation in terms of reimbursement. So, and we need more prospect study, then we can do that.
Thank you.
Okay, thank you, Professor Kim.
Thank
so
you.
we are looking forward to our next presentation.
Thank you very much.
So I would like to introduce the third speaker. The third speaker is my friend, Professor Hang. He is chair professor of the Institute of Clinical Medicine, College of Medicine, National Yang Ming Chiao Tang University. And especially he is now currently the president of Taiwan Liver Cancer Association. So Professor Hang is a true specialist for HCC. Please give your lecture.
Thank you for Chairperson, Professor Kurosaki, your kind introduction. So ladies and gentlemen, today my talk is a personalized approach for optimal treatment selection in HCC. This is my disclosure. So today I will talk about regarding the AI assist in HCC treatment selection. So I'm focusing on the early stage into the intermediate and also the systemic therapy. So as you know, the current AMPCOC or also the ESOD guideline suggests that for early or very early stage HCC, surgical resection or radiofrequency ablation is the standard care to achieve the curated intention. However, after the surgical resection or the radiofrequency ablation, there's still a very high risk of recurrence after the surgery or radiofrequency. Around 15 to 60% of cases will experience the HCC recurrence within 5 years. So regarding the time of recurrence, there is estimated that within 2 years, there is a peak of early recurrence, and after 2 years, there was a second peak around at year 4 or year 5. In our previous study, we clearly showed that for HBV-related HCC, baseline HBV viral load is highly associated with the late recurrence. In our definition, it's a recurrence after 2 years. For patients with a high baseline HBV viral load, there is a high risk of recurrence as compared with those with low viral load at baseline. However, for the early recurrence, there is no difference between the two. And in our previous study, also want to try to find a biomarker to select which kind of patient will have a high risk of HCC recurrence after the surgical resection. And interestingly, we find that for patients with a higher serum interferon gamma level will associate with a lower risk of recurrence. So it indicated that the host anti-tumor immunity may have a potential it may serve as a potential marker for HCC recurrence. And also we look at the clinical trial design for the UMBRACE 050. They use the atezolizumab adjuvant immunotherapy after resection or ablation for high-risk patients. And this study showed that after 1 year of observation, that with around 30% of patients would reduce the risk of recurrence. However, if you look at the criteria for the high risk, there is quite diverse. For selection, around higher than 5 centimeter, or multiple tumor, more than 4, or tumor with vascular invasion, or with poor tumor differentiation. But for the ablation, it's a single tumor, 2 to 5 centimeter, or less than 4 tumor number, and less than 5 centimeter. So this is quite diverse. And recently, we know that the AI can assist the prediction to predict the recurrence of HCC after surgical resection. The one famous study is the eraser model, which we can use to predict the recurrence by using the preoperated clinical feature or incorporated with the post-operative pathological feature. And also the machine learning model by using the CT radiomic can predict the presence of the microvascular invasion. So in our recent study, we incorporate the 500 patients by using the clinical and the CT radiomic feature to incorporate a genetic algorithm for prediction recurrence after surgical of liver cancer, we so-called GASO model. By using this GASO model, we can perfectly predict which patient who had a high risk of recurrence or low risk. And also, we validate the criteria from the UMBRE 150, and we found that by using this GASO model, we can further define which patient who really had a high risk of recurrence. And for intermediate stage HCC, as we know, this is a quite heterogeneous subgroup. And for current BCLC and also SOT, he has changed a little. In the past, only one choice, that's test. And right now, for diffuse infiltrated tumor, we suggest systemic therapy. And as you know, in the Apple consensus in 2019 and 2020, they defined a term of a taste and suitability based on the tumor morphology and also based on the tumor burden. For tumor morphology, some tumor morphology such as a confluent, multiple, or infiltrated tumor is not indicated for taste. And for tumor burden, up to 7 out, who will likely to become a tertiary failure or become a triple B or C. And recently, we further defined for patients with 7 out into intermediate and high tumor burden by using the 7-11 criteria. So we further divide 7 patients between 7 to 11 into the intermediate stage HCC, and for patients up to 11 out belong to the high tumor burden. So for patients with within 7, between 7-11 and to 11, we can clearly show that for patients with a high tumor burden, the objective response rate is really poor, and also the objective response rate can reflect on the recurrence-free survival and also on long-term survival. For patients with high tumor burden, the median overall survival was less than 1 year. However, for patients between 7-11, the median survival still have 22 months. So in our data show that for up to 11 out, it is those patients should receive the systemic therapy instead. But for between 7-11, they still have a chance to receive the test. Apart from the tumor burden, as we know that the radiology pattern also determine the outcome of initial and the subsequent tests. So recently, we used our data cohort, but dividing the intermediate stage HCC patient into encapsulated type, extranodal growth, or the massive type, or the infiltrated type. We show that the tumor response was the best for the encapsulated type, followed by the extranodal growth, then the massive type, and also the worst by the infiltrated type. And also this response rate can reflect on the overall survival. Even the response is very similar for patients received the subsequent test. So in our study also showed that there is a highly correlation with the tumor burden and the tumor radiologic feature. For patients with up to 11 out, most of patients belong to confluent or multiple tumor or the infiltrated type HCC. So in our data show that for patients with confluent tumor or infiltrated type HCC, those patients should select systemic therapy. So currently, the updated Taiwan Liver Cancer Association, the 2023 updated guideline also suggests for patients with unfavorable radiology pattern, we'll select systemic therapy. And recently, we also want to try to use the so-called AI or evolution learning model to help us to select the radiology pattern. And by using the clinical feature and also the radiomic feature, we clearly successfully built up a so-called race state-based deep learning model. And we compare with the AI-based morphology classification and also by the human. We saw that the objective response rate and also for the overall survival was quite similar. So AI can assist on this job. And for the advanced stage, HCC, as you know, currently the immune checkpoint inhibitor, so-called HCC immunotherapy, is the standard of care for advanced stage patient. However, for HCC, only 20 or 25% of cases belong to T-cell inflamed tumor, which can respond well to the immunotherapy. And currently, the first-line systemic therapy, including the atezolizumab and also the STRIDE regimen. And most recently, another dual IO combination by using the EP-NEMO has announced make the primary endpoint the 9DW clinical trial. So in near future, we may have a 3 IO treatment for the first line for HCC, advanced HCC. And some study also show that the machine learning model using the CT radiomic can help us to predict the Levatini monotherapy response. However, in using this model, they can clearly select the patient who can respond to the Levatini and also the progression-free survival, but it could not differentiate the overall survival. So is there any model for the HCC immunotherapy? As you know, the one study by using the molecular marker, including the transcriptomic analysis and also the in situ analysis to define the so-called tetrapaper response signature. But it incorporated 10 gene to building this model. For patients with high or low, they can see a different progression-free survival and the overall survival. However, this so-called ABIs is so complex, and I think it's not so clinical practice relevant. And regard from the genetic marker, gut microbiota, which has been reported to associate with many human disease. And for immunotherapy, gut microbiota can differentiate and modulate the outcome of a certain type of tumor undergoing immunotherapy, including the melanoma and the lung cancer. So recently, we're using the gut microbiota and their metabolite try to predict their treatment outcomes. First, we compared the 20 responder and the 21 non-responder, and we found that there is a quite difference in the diversity and also in the composition between the responder and the non-responder and also the healthy controller. And also we found that the patient with progression will have enriched in the protein 9. And for patient with a responder, they have a higher reach of lactospira and lactose clostridium. And also we compare with the secondary bile acid, which may have an impact on the modulation of the tumor microenvironment, and found that there is a highly difference between the UDCA, UCA, and the MDCA level between the responder and the non-responder. And also we use the 33 HCC patient for the validation. We found that a patient with a preferable gut signature or unfavorable gut signature have a different outcome, including the progression-free survival and the overall survival. So is there any chance to use the gut microbiota to predict the HCC immunotherapy? As we know, the gut microbiota might reflect the our healthy immunity and also their metabolite can further change the tumor microenvironment. According to our data, by using the gut microbiota and also the metabolite is highly associated with the outcome of HCC immunotherapy. And recently, one phase 1 clinical trial by using the FMT preconditioning for the patient with melanoma before anti-PD-1 immunotherapy. After 2 times of the FMT, using a very deep response by the immunotherapy for the patient with melanoma. So this study highly implies that in the future, change of the gut microbiota may have a potential to predict the outcome, although improve the outcome of HCC immunotherapy. And also, you know that different types of etiology of HCC may have a different outcome of IO immunotherapy. In this study in Nature 2021, showed that the NASH patient would limit anti-tumor surveillance by using the anti-PD-1 immunotherapy for HCC. Therefore, most recently, we want to compare is there a difference in gut microbiota between the viral versus non-viral etiology HCC in our patient cohort. Interestingly, we found that for patients with viral or non-viral HCC, all those patients belong to unresectable status. The gut microbiota, the diversity were quite different. And also there are different composition of the gut microbiota for the viral HCC between the non-viral HCC. So this data may support that the different etiology of HCC may have a different gut microbiota and may also impact on the outcome of HCC immunotherapy. So, but the microbiota study is so complex. I did because it's a large, huge data after the NGS study. So AI can assist this job. So recently we combined the AI derived model incorporating the clinical feature and also the gut microbiota, and we can successfully make a personalized probability prediction to predict the outcome of a HCC patient receiving the immunotherapy. So this is the example. We can show our cases has a different survival curve by using this AI-derived model. And also another issue is the sequencing therapy after the IO. Because although different mode of action may be the treatment choice for the sequencing therapy after the IO, but is there any some hint can help us to choose the right drug? So I think this is one report by using the whole genome or whole exome sequencing and the RNA can on the tumor biology. In this study, they show that there's still a significant portion of patients can select a droppable genomic alteration, and some of them can get the clinical benefit by use way to select the suitable drug. So in conclusion, ladies and gentlemen, the treatment options for HCC are diverse and they require a personalized approach to select a best treatment. And the application of the AI can predict the risk of a recurrence of HCC after surgical resection. In our GASO AI model can be used to determine whether adjuvant immunotherapy is needed after the surgical resection of HCC. For BCLC-B intermediate stage HCC, our 7-11 criteria can further classify the intermediate and the high tumor burden, and also our radiologic pattern can make it in decision making before the test. And there is an association between the gut microbiota and the metabolite on the outcome of HCC undergoing immunotherapy, supporting the potential role of gut microbiota in selecting patients with HCC undergoing immunotherapy. So, ladies and gentlemen, thanks for your attention.
Thank you for your very comprehensive and nice lecture. Is there any question or comments from the floor? Yes, Professor Oka.
Thank you. A very excellent presentation. I'm much interested in the interrelationship between microbiota and the response of ICI therapy for HCC. You show that the biota signature is associated with this anti-tumor response of ICI treatment. But do you think, what do you think about the possibility of therapeutic intervention toward gut microbiota?
Yes, it's a very important issue. So in order to answer this question, we had do pre-work to compare the baseline and the 2 months after the IO to collect the feces sample to compare is there any changes between the responder and non-responder. But in our pilot study, we did not find a very clear changes for one person after the immunotherapy. So maybe the baseline, the gut microbiota may have potential, just can predict the outcome of the tumor response.
Thank you.
Thank you.
May I ask you one question? I was impressed of your GASO prediction model for the recurrence, and maybe the high risk of a recurrence could be a candidate for the adjuvant. My question is, GASO is a predictor of recurrence, but could it also predict the response to immunotherapy?
Yes, thank you, Professor Kurosaki. You are very important issue. Recently, I think the GASO first author is stay here, is Professor Yichen Li. And so, in our GASO model, it's based on the cohort from the surgical resected patient. So I have not been moved to for the advanced HCC patient. So, but it's a very interesting issue. We can try to apply this model into the advanced stage HCC in the future. Thank you.
Thank you. Is there any other question or comments? So thank you, Professor.
Thank you.
Okay, so I'm going to introduce last speaker, Professor Masayuki Kurosaki. He is the head of Department of Gastroenterology and Hepatology, Musashino Red Cross Hospital. And also, he is the Vice President of Japan Liver Cancer Association. And he is one of the most important person of Japan Society of Hepatology. And he is the president of 61st annual meeting of JSH next year. So please start your excellent lecture, Eliminating Viral Hepatitis C, not to leave anyone behind from HCC cure. Please.
Thank you. Thank you. That title was a misprint. That was the title of my luncheon seminar lecture. The actual title of my presentation is Optimal Treatment Selection in Intermediate Stage Hepatocellular Carcinoma. And I would like to start. For the interest of time, I would like to make my presentation short. This is the overview of treatment for hepatocellular carcinoma. Due to the development of advanced systemic therapy for advanced stage HCC, the prognosis of advanced stage HCC has prolonged for sure. But today I would like to focus on the treatment options for intermediate stage HCC. This slide is already explained by Professor Huang, so I would like to make it short. But patients within intermediate stage HCC but has a high tumor burden is not a good candidate for treatment with TACE, because when these patients are treated by TACE, they are likely to develop TACE failure, or they are likely to go on to Child-Pugh B or C after TACE. So TACE unsuitability is defined based on the tumor burden, such as up to 7 criteria out. These two studies show that among patients who are up to 7 out, when patients were treated by lenvatinib and compare the OS versus TACE, the patients treated with TACE, treated with lenva had a longer overall survival in the comparison by propensity score matched comparison and also IPW adjusted comparison. I would like to show you one representative case, 80-year-old male BCLC stage B, but you can see the nodule is a confluent multinodular type with multiple nodules. The max diameter is 5.4 centimeters, so he is up to 7 out. According to the taste and suitability criteria, the tumor burden is taste unsuitable, and tumor morphology is also taste unsuitable. These patients are now treated by systemic therapy, and actually this patient was treated with Lemba. You can see that 30 days after the start of lenvatinib, there is a marked decrease of blood flow and shrinkage of HCC. So systemic therapy such as lenvatinib is very effective in patients who are taste unsuitable. However, the characteristic of lenvatinib is that effectiveness is dose dependent. I would like to show you two of our studies. The first one is the impact of 4 weeks relative dose intensity of lenvatinib and its effect to the overall survival. Patients who can receive high dose of lenvatinib and maintain relative dose intensity over 70 have a long overall survival. However, if the patient cannot tolerate high dose, the OS is shortened. The second data I show you here is the impact of 4-week relative dose intensity after the first CT evaluation. If the patient has a SD or PR on the first CT, and also have a PR or CD on the second evaluation CT, the survival is very favorable. However, even if the patient has a response or SD on the first CT, but go on to PD on the second CT, the prognosis is worse. When we compare these two patients, the 4-week relative dose intensity of lenvatinib after first evaluation CT is low, decreased among patients with PD. So high dose of lenvatinib is preferable to prolonged survival, but not all patients could tolerate this kind of high dose lenvatinib. So nowadays, the solution is to give a local regional therapy such as TACE to these patients. This is the actual data of this patient. He had a response. However, he experienced adverse events and led to the dose reduction. After dose reduction, there was a reappearance of blood flow and had a PD. We performed tests to this patient and this patient had a CR. This kind of on-demand TACE is widely performed in Japanese hepatology specialists. The concept of on-demand TACE after lenvatinib is to start lenvatinib and give on-demand TACE in selected nodules that the efficacy is limited, probably due to the reduced dose of lenvatinib. We have performed such a kind of on-demand TACE in 26 patients. And the median OS of these patients was 33 months, and the median PFS was as long as 13.2 months. So lenvatinib plus on-demand TACE has a good OS and good progression-free survival. When we compare the patients who are treated by lenvatinib followed by on-demand TACE and who are treated by lenvatinib alone, there is a marked difference in overall survival between these two groups. When we look into the patients who had received lenvatinib plus TACE, these patients had a low relative dose intensity of lenvatinib before TACE. That is the reason why they received TACE. After TACE, the relative dose intensity of the lenvatinib in these patients is still low. However, even though the patient cannot tolerate high dose of lenvatinib, the OS is prolonged, which means that addition of a local regional therapy such as on-demand TACE could improve the survival with low dose of lenvatinib. Another strategy is the scheduled TACE combined with lenvatinib. This is a famous tactical trial. This is a single-arm study giving 2 or 3 weeks of lenvatinib before the first TACE and TACE is repeated on demand, and the lenvatinib is continued. The most characteristic of this TACTICS-L trial is the high rate of CR obtained. For example, in patients who are up to 7 out at baseline, the CR rate was as high as 59%. Among patients who are up to 17, CR rate was as high as 72.5%, which means that among BCLC stage B and TACE unsuitable, high rate of CR could be obtained by this kind of scheduled TACE. Such kind of scheduled TACE was performed in an institute for 9 patients. All of them are BCLC stage B. And I would like to show you one representative case. This is an 80 years old male child, pube A, had a massive HCC with portal vein invasion and had a resection. This patient can achieve the R0 curative resection, that the pathology was poorly differentiated. After 4 months of surgery, there was a recurrence of small 3 nodules. Because the size was small and the number was 3, this patient was up to 17. However, this patient had a baseline portal invasion and pathology was poorly differentiated. We selected to give a scheduled lenvatinib followed by TACE in these patients. We started lenvatinib with 8 milligrams and gave TACE and continued lenvatinib with low dose and then gave a scheduled TACE. These patients achieved CR. So these kind of patients who are up to 17 or who may be cured by TACE but has a high risk of recurrence, this kind of a scheduled TACE could be very effective. Going back to the lenvatinib, all cohort of lenvatinib, we had 44 patients with BCLC up to 7 out treated by lenvatinib, plus minus TACE. Among these 44 patients who are treated by lenvatinib, all of them were up to 7 out. Overall survival was 22.8 months. A PFS was 6.2 months. When we look into the factors that is associated with OS or PFS, as you can see, for the OS, maximum diameter is not a predictor of OS among this patient, and the number of tumors is also not a predictor of OS when treated by lenvatinib. The predictor was an RB score and neutrophil lymphocyte ratio. For the progression-free survival, maximum diameter was again not a predictor for the longer PFS. However, the number of tumors was a predictor of PFS in the univariate analysis, but marginal in multivariate analysis. This is the characteristic of lenvatinib. Going to the atezolizumab, this is the data of the atezolizumab treated patients in Japanese Red Cross Hospital cohort. The median OS was 24.1 months and the median PFS was 9.4 months. The best predictor of atezolizumab is AFP response. If we can obtain a rapid decrease of AFP of 20% compared to baseline, the PFS is long. And if the AFP response is over 50%, the PFS is longer. And if 75 or over 75%, PFS is much longer. This is one representative case. This case had a BCLC stage B, atezolizumab was selected and had a good response. These patients experienced liver dysfunction and we became cautious and stopped atezolizumab and gave TACE. There was a good response to TACE and this patient finally became drug-free and CR. For the IMbrave 150, when we look into the IMbrave 150 data, BCLC stage B, the number of patients was 46 and CR was obtained in 11 and PR was obtained in 33 and PD was only 4%. So atezolizumab is also very effective in BCLC stage B. This is a spider plot showing that the responder has a long durable response, but among SD patients, there will be a PD during the course of treatment. So among patients who has a response or who are within the SD, the strategy is to give the local regional therapy, such as LEM-TACE, in this case, atezolizumab-TACE, to control the residual tumor in the liver. This is a paper by Professor Kudo showing that TACE unsuitable intermediate HCC were consecutively recruited. And among 110 patients, resection was performed afterwards in 7 patients, ablation 13, TACE, violent TACE in 15, and 35% of patients achieved CR. So this kind of approach, not only lenvatinib, but given TACE or resection local regional therapy after the start of atezolizumab in BCLC stage B could improve the curative conversion and prolong survival. Now, I would like to show you the data of the atezolizumab treated BCLC up to 7 outpatient in a hospital. The number of patients is 57. The overall survival was 21.8 months and median PFS was 8.1 months. The factors associated with OS or PFS is listed. Like lenvatinib, maximum diameter or maximum number of tumors was not a predictor of overall survival within the BCLC-B up to 7 outpatients treated with atezolizumab. Again, PFS, diameter and number of tumors was not a predictor for the PFS. This is not a direct comparison, but I listed the predictor of OS and PFS among BCLC up to 7 outpatients treated with atezolizumab or lenvatinib. For the overall survival, number of tumors or maximum diameter is not a predictor of OS in patients treated with atezolizumab or lenvatinib. Liver function was a predictor of overall survival, especially in lenvatinib. For the progression-free survival, liver function is a predictor of good PFS in lenvatinib, but not in atezolizumab. Of note is the number of tumor is a predictor of a PFS is lenvatinib, but not in atezolizumab. So, in summary of this analysis, tumor size and the number of tumors was not a predictor of OS for either atezolizumab or len in BCLC-Bs up to 7 out. Tumor number was a predictor of PFS lenvatinib, but not in atezolizumab. So atezolizumab may be an optimal treatment for all comers of BCLC stage B because of the paucity of baseline factors that predict OS or PFS. RB score is an important factor of lenvatinib, so it may be an option for patients with good liver function reserve with a small number of HCC nodules, especially if atezolizumab is to be spared for the future treatment option. So again, I go back to the overview of the treatment of HCC and the treatment option for the intermediate stage HCC. In TACE unsuitable BCLC stage B, initial systemic therapy such as lenvatinib or atezolizumab with or without on-demand local regional therapy may increase the chance of CR or promote longer survival. However, as I mentioned in the prior slide, there may be a characteristic of a lenvatinib or atezolizumab, but we do not actually know at this timing which regimen is better for the intermediate stage HCC. These are my collaborators. Thank you for your attention.
Thank you, Professor Kurosaki, for your excellent lecture. Any question or comment from the audience? No? Professor Okawa?
Thank you for a nice presentation, Professor Kurosaki. You summarized the therapeutic strategy as to intermediate stage with high tumor burden, such as UT 7 out patients. In Japan, as an optimal treatment. Initial systemic treatment followed by on-demand test is often used. But which drugs of adalimumab and then should be used?
Thank you for your question. That is the most big problem or debate in our country. In the patients who may be suitable but need more intense treatment, I will select lenvatinib with scheduled test for these patients. However, as I presented in the data, patients who have multiple nodules are not a good responder for lenvatinib. So in patients with bilobular multinodular HCC, I would like to start with atidomumab. And if there is a good response and small number of residual nodules, I would like to select on-demand test. But there is no clear-cut criteria to separate which patients is better for lenvatinib and which one is for atidomumab. That is a question for future.
Thank you, Kurosaki. So maybe Professor Dokumachi making a close remark.
Thank you very much. We had really very important four speakers, and they discussed about the hepatocellular carcinoma treatments and the also surveillance of the hepatocellular carcinoma. And thank you very much, Professor Okawa. Discussed very well all the speeches, and also thank you very much my co-chairs, and also the big thanks for you, for the audience. Thank you very much. I close this session.
Thank you very much, speakers and moderators.